Hello everyone, today in series of Dr. Access KOL interviews, we have with us Dr. Dhruva Chaudhry, who is a Senior Professor and Head Department of Pulmonary and Critical Care Medicine, University of Health Sciences in Rohtak. Thank you so much, Doctor, for the interview.
My pleasure.
So let's begin with the first question. What are the adverse effects of diabetes on lung functioning?
You see, diabetes has a multiple effect which are there. Unfortunately, people have ignored it over a period of time. It can affect particularly every system as far as the respiratory part is concerned. It can have a problem in terms of responses to hypoxia, to hypercapnia. It also affects the respiratory muscles, because of which you can find out ventilatory defects. And along with it, it also affects the pulmonary microvasculature, because of which you can have symptoms, but because the reserve which is there of microvasculature is so much that people are not able to make out of it. Therefore, that way, it is something a neglected area as far as the pulmonary microangiopathy is concerned. But nevertheless, our data is showing that people who have diabetes of a long-standing, like your diabetic microangiopathies which involve kidneys, which involve eyes, over a period of time, the lungs also get involved and people may become far more symptomatic than otherwise the disease processes, because of which they are breathless they may be.
Okay. So doctor, can you elaborate on the management of pulmonary microangiopathy?
You see, this is an entity which is evolving, and though there is a literature, if you take it out starting from mid-70s, a lot of papers were published up, but of late attention has been coming to it because people trying to use large number of drugs for inhalational therapies and especially inhalational insulin. That's how it became a little more prominent. The treatment for this microangiopathy is the same as for anything as all other microangiopathies in diabetes, a good control of diabetes. That is the first thing. Second is picking them early, and that's a challenge. In the kidneys or in the ear or in the eyes, you pick them early, but how to pick up is a little challenge, and that is where my role starts as a pulmonologist, where you can request your pulmonologist friends to do a diffusion studies, both in the lying down as well as the standing. Normally we do it in the sitting and standing, but if we do it in the lying down, it is expected that our DLC or the diffusion capacity should increase. But unfortunately, sometimes when you find it out and it is not increasing, the person is a diabetic, that is the first pointer of the clue that person is having a microangiopathy. And alternatives, your radiologist friends can be of help to you, where they do a perfusion CT scans. It's the same CT, algorithms are a little different, software is different, and it can pick it up like you do fluorescein angiography to pick up your microangiopathy before it becomes overt. So you need to pick them up when it is occurred, when it is not manifesting. But as you ask the question, treatment remains the same. Control the diabetes and it's likely to reverse back.
So doctor, at what stage during diabetes treatment a pulmonologist can be consulted?
You see, pulmonologists can be considered at different levels. We are not talking in terms of pure disease which is diabetes. They may have an association with COPD, they may have an association with the asthma, they may have an issues related to air quality indices and air pollution, both outdoor and indoor. But what we are talking today is that the diseases which are not per se respiratory but as a consequence of diabetes. In those, if you find that the person is becoming breathless disproportionately and cardiac functions are normal, or if somebody has got issues which are related to sleep apneas, where you can have a significant number of these patients can have sleep apnea syndromes, or where you find a diabetics who have got an autonomic neuropathy. There also you pick them up, because what one has observed and seen and literature is there is that bronchomotor tones may go away. The adrenergic responses which are there, they may go away. So you may have a less than normal response. If any person who is a diabetes and COPD or having it, that is the time you start looking at it in these patients that yes, I need to have a consultation of a pulmonologist.
And so, what are the complications with pulmonary microangiopathy?
You see, this is an evolving field, and people don't have followed these cases for much longer time. But what it is expected is that the reserves, as it starts shrinking, you may have a disproportionate breathlessness. That is the one, because what we are finding is diffusion initially may be normal, gas exchange remains normal for a very long point of time. But nevertheless, as the disease evolves, because it's an early days for us also, and probably we shall be able to answer it, because now we are looking at it as a part of one of the postdoctoral dissertation, that how diabetes is affecting it and how we diagnose it. Probably answer will come up in the future, but whatever the literature we are seeing is primarily is that it runs the course parallel to microangiopathies in other organs, being the only difference is that probably they may not be as symptomatic when they are alone. But yes, if you have a diastolic heart failure or you have any congestive failure, if you find that the people are disproportionately breathless, or you are finding somebody has a respiratory problem with the diabetes and your symptoms of breathlessness are disproportionate, please do think about it. And that is the time you need to look at it and see how the diabetes is controlled. I think that's what we need to see it. And I was talking to my colleagues in PGI Chandigarh, in particular Department of Pathology. They were also wondering that they used to think that probably patients have gotten pulmonary arterial hypertension or pulmonary vessel sclerosis of some unknown region. But once we discussed, and I'm grateful to them, they, in particular Dr. Uma, who gave us the slides which prepared it up, they realized probably a large chunk was missing. So it's an entity which large number of clinicians are aware of, irrespective of the specialty. And for me also, when I presented, preparing for this talk, it was again a sense of a deja vu and sense of how limited we know. I think we need to keep our eyes and ears wide open and be receptive to new ideas.
Okay. So apart from therapy, what would you suggest as a management of pulmonary microangiopathy?
Prevent diabetes, treat diabetes, that's it. A good control, you will have reversal. Data shows it that microangiopathy in incipient stages, they go back. Therefore, good control of diabetes is the key. Whether it is pharmacological, non-pharmacological, that I leave to your diabetologist or endocrinologist. But most important person is the patient itself. They have to look after themselves, and if they will not, then they can land up with the problems which probably could have been avoided within the time.
Thank you so much for this interview. It was a pleasure having you here.
Same here. Thank you very much.